Today I'm going to be talking about chest x-rays and how to interpret them. Hopefully it shouldn't be too long a video because chest x-rays are quite a simple task. And we're just going to get straight into it. So chest x-rays are made up of three main sections. So the first one is confirming the patient details. The second step is assessing the actual quality of the chest x-ray. The third step is actually what does this chest x-ray show us? And what can you interpret from it? And then at the end, you can kind of summarize all your findings, if there's any kind of important positives, any important negatives to exclude, and then kind of discuss your management plan as well if you want to. Okay, so straight into it. In terms of the patient details, there are a few main things that you have to include. So when you get given a chest x-ray in front of you, ask for confirm the patient name, the date of birth, and the hospital number. And then you also want to check the date and the time of the chest x-ray, as well as asking if there's any previous imaging or any kind of indication for actually ordering this scan. So in terms of those three, you'll basically do that for any kind of imaging, any kind of blood interpretation kind of station in an OSCE, anytime in the hospital as well. So main things are the patient name, date of birth, hospital number, if there's any kind of previous imaging, and then the date of time that the actual, in this situation, chest x-ray is taken. Okay, so the way to assess the quality of the chest x-ray, we use an acronym called RIPE, and in terms of to actually determine what the chest x-ray shows, it's an A to E approach. So A, B, C, D, and E. Okay, so let's start with RIPE and actually what all of that means. So the R stands for rotation, I stands for inspiration, P stands for projection, and E stands for exposure. Basically, what we're trying to do with this is just say whether or not this chest x-ray is good enough for us to interpret if there's any kind of pathology or anything wrong with the patient that we need to actually figure out. If it's not a good enough quality chest x-ray film, we'll need to do another one. That's all that this step provides us. It doesn't tell if there's any kind of pathology or anything. Okay, let's also then just write out kind of A to E as well. Okay, so A is airway, B is breathing, C is circulation, D is diaphragm, E is everything else. Again, any kind of interpretation, like station OSCE or anything actually in the hospital, it's all about working systematically. That's what these kind of acronyms allow you to do. And it allows you to work systematically and make sure you don't miss anything of importance. Okay, so got a chest x-ray here. Let's start kind of writing down and kind of going through what all of these things mean. So starting off, we'll assume that we've checked all the kind of patient detail, date of birth, hospital numbers and all that, and we'll just start off with RIPE. So in terms of rotation, the thing that we want to check are the medial aspects of the clavicles equal distance to the spinous processes. So what I mean is, hopefully you can see that here are the spinous processes and here are the clavicle heads. I.e. now, are these spinous processes equal distance between this point and this point? Here we can say, yeah, they kind of are. If the spine's processes are too far to one side or too far to another, what this means is the patient wasn't lying completely flat when they're facing the actual chest x-ray machine. Their body's rotated one way or another. For example, if the spinous process, if the clavicle was here, the spinous process were here, and the other spinous process was here, it's rotated one way or the other. Okay. The next is for inspiration. This is basically to determine, do we have a good enough amount of lungs that we can actually see? So, i.e., did the patient breathe in? So, can we count the number of either anterior or posterior ribs? So, the magic kind of numbers you want to know are 5 to 6 anterior ribs or 10 posterior. Okay, so let's try counting this now. So we've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 of the posterior ribs. And if we count the anterior, we can see 1, 2, 3, 4, 5, 6, 7, 8. So yeah, this chest X-ray has an adequate inspiration. We can actually see enough of the lungs to make any kind of interpretation. Okay, the next is for the projection. Okay, so what we mean by projection is either is this an AP film or a PA film. So if it's AP, anterior posterior, versus PA, posterior anterior, what we're trying to work out here, what this allows us to work out is mainly the heart size, right? So if I try drawing some kind of image, so let's say that this is a person, and that's their chest. This little box here is the chest X-ray machine, and it's going to kind of fire out the imaging stuff. And then we're going to draw a little heart here. Let's say that this is and then, okay, you have the film here, which is where the actual chest X-ray, i.e. this kind of image, projects onto here. If this is an AP film, which is what we have here, i.e. the person is facing the actual chest X-ray machine, their heart is at the front, i.e. this is anterior posterior. So their heart, when it projects onto here, is going to appear to be larger on the chest X-ray. However, if we switch this round and make it a PA film, where the heart is at the back, because the person's facing away from the machine, the heart has less of a shadow, and we're able to actually determine what the heart size is. So hopefully that makes sense of what we mean by projection, i.e. AP or PA film. So the way to kind of determine, normally there'll be like a little sign somewhere on the actual chest X-ray that'll say like PA or AP. By default, most chest X-rays are a PA film. So what you can look for are kind of the actual sizing of the lung. So here we can see that the lungs are quite long and thin overall, right? That's one indication that it's a PA film. If the lungs are kind of like squashed and fat, so if they're more like kind of that shape, that's more likely to be an AP film. Also in terms of the clavicles, here we can see that the clavicles go over the actual lung fields. You can see some lung field there and there. That also indicates the PA film. If the clavicles are kind of on top like that, that can normally indicate that it's an AP film. And then lastly, we have E, which is exposure. So this is basically, is the chest X-ray too bright or is it too dark? So the way to determine this is, can you see the vertebral bodies behind the heart? So if here's the heart there, can we see each of these vertebral bodies? I.e., can we see kind of gaps in between? Can we see the actual bones? Yes, we can. Therefore, in terms of exposure, this chest X-ray film is adequately exposed. Okay, so that's all you need to do for RIPE. We can now say that yes, this chest X-ray is is adequate for us to then interpret whatever it is that we want to interpret. Okay, so now let's go through kind of an A to E approach, what kind of stuff we would actually look for. So starting off with A. A stands for airway. So the thing we're going to be looking for, we're going to start off at the trachea, which is here. Trachea should be central. The other option is either deviated. It's easy to kind of think that potentially there's a bit of it's deviated. If the trachea is deviated, you'll know it. It will literally be like that or like that. If there's like a little bit of a wiggle or something, it's probably midline. You don't need to worry about it. So here we can see that the trachea is central down here. Then we're going to look for the carina, which is basically the bifurcation of the trachea into both bronchi. Think of it the way that the road splits. So you can see that here. So the trachea comes down here and then splits into each bronchi, the right and the left. The right here and the left there. So what we're going to be looking for is there any kind of foreign bodies or like an NG tube, nasogastric tube, which goes from the nose down into the stomach. Is there anything kind of blocking it? If anything does go down, it's more likely to go down the right bronchus because of the angle of the right bronchus is more kind of vertical than the left bronchus, which kind of goes more at an angle like that, which means that objects are more likely to go into the right lung as well, and I from the right bronchus. The next thing we need to then follow along on the respiratory tract from after the trachea to the carina to the bronchi is the hilar regions, which are over here and here. This is just kind of the vasculature of the lungs, and we're kind of having a look if it's enlarged or not. If there's some kind of unilateral enlargement, this could indicate something like TB or any kind of malignancy. If there's bilateral hilar enlargement, this could indicate sarcoidosis. So in terms of any kind of trachea deviation, which is the main thing that you're going to be looking for in airway, if the trachea deviates towards the lung, i.e. let's say it goes that way, and this is the lung problem, you'll be thinking something like atelectasis or some kind of pneumonectomy, i.e. the lung being removed. Atelectasis is basically when one lobe of the lung collapses. So remember that there's the right lung, which is this one, and this is the left lung. The right lung has 3 lobes, so it divides like that and that. The left lung has 2 lobes, this one and this one. And the reason the left lung only has 2 lobes is because the heart's on that side as well. So if one of these lobes collapses, then that's called atelectasis. If, for example, there's a lower lobe collapse in atelectasis, you'll see something called Sales sign. If it's an upper lobe collapse, you'll see a golden S sign. You can kind of Google images of what those look like. If the trachea deviates away from the side, so let's say this lung is the problem and the trachea goes that way, you'd be thinking something like a pleural effusion or pneumothorax, whether it's tension or not. So it's almost like there's stuff going on in this lung and the trachea is now being pushed away. Okay, so next is going on to breathing. Okay, so for breathing, what we're going to look for is first look at the actual lungs. They should be black, as we can see here, with these kind of fine white lines on them. So hopefully you can appreciate that there's some kind of lines that you can kind of see all over here. These are just normal lung markings. They should be there. So once you can just say that, yes, there are normal lung markings, you want to then compare each zone in the lungs with the right and the left. So comparing the right side to the left side. You're not looking at the actual lung lobes, you're looking at the zone. So if I draw a line arbitrarily here and here, this is the upper zone, this is the middle zone, and this is the lower zone. So you can compare the right with the left. This side and this side, this side and this side, this side and this side. So if we compare this upper zone here, there's nothing any kind of difference there. If we compare this middle zone, there's no kind of difference here or here. And if we compare this lower zone here and here, there's no kind of difference. When I say difference, I mean if there any kind of consolidation, which is It's like a clumping. It's normally associated with something like pneumonia. If there's any opacity, which is some kind of like whiteness, or any lucency, which is like kind of blackness. Okay, so airway, just look at the trachea, the carina, the bronchi, then going on to breathing. Have a look at the lungs. Are there normal lung markings? And then you're just going to compare upper, middle, and lower zones. Then you're going to go into C, which is circulation. Now, if you have an AP film, you're not going to really be able to determine the heart size. If you have a PA film, you can. This is a PA film, which is okay. So we're going to look at the heart, which is kind of like here, and there's the aortic knuckle as well. So in terms of the heart size, it should be less than or equal to 50% of the thoracic cavity. This here is the thoracic cavity. This here is the heart. We can say that that is less than 50%, i.e. there is not cardiomegaly. Heart, megaly being big, i.e. there's no heart enlargement. After we've determined if there's no cardiomegaly, we need to see, are the heart borders crisp and well defined, i.e. can we draw a nice line there and there? Yes, we can. That's important. We actually need to be able to see the heart size. If we can't, then there might be some kind of consolidation somewhere. Going on to D, which is diaphragm. This is basically now having a look at the diaphragm here. So normally the right side, which is here, will be higher than the left side. The reason for that is because you've got your liver here, and that kind of pushes up on the diaphragm. So what you're going to be looking for are these bits here, which is the costophrenic angle. Phrenic being diaphragm, costo referring to the ribs. So if there's something called costophrenic blunting, i.e. these angles here are not sharp, i.e. it's almost like someone's kind of colored it in and it just kind of merges, i.e. it's blunted. This could indicate a pleural effusion. The next thing you want to have a look for is a gastric bubble, which is here. This is normal. You don't need to worry about it. However, you should never see free air below the diaphragm. If you do, for example, if there's like a small slit like that, that's called pneumoperitoneum, which indicates some kind of bowel perforation. Don't get that mixed up with the gastric bubble. Gastric bubble is normal, pneumoperitoneum is not. Then after that, we're going to go on to E, which is everything else. Okay, so basically what you're going to have a look for now is there anything else that you can see? Is there some kind of pacemaker with wires going to the heart? Is there an NG tube coming down, going to the stomach? Are there any kind of bone fractures anywhere? Have a look at the clavicles, have a look at the scapula if you can see anything. If there's any kind of surgical staples you might see, if there's any kind of heart valves you might see, if there's any other foreign bodies around, for example, if someone's got a coin stuck in their throat or a bronchi, have a look there. If there's any kind of surgical emphysema, which is air in the fat, so you'll see that kind of along the sides here, which is like more looking at checking the soft tissue if there's any damage there. And if you can be able to do a RIPE and an A2E, that is basically your chest X-ray interpretation done. One other thing to mention is something called rib notching. At first I didn't really know what that meant. So very quickly, if we just zoom in, here you can see that there's the lungs, right? There's the ribs on the lungs. This is the superior part of the rib, and this is the inferior part of the rib. If there's some kind of notching, i.e. it kind of dips down like this, we'll call that superior rib notching. This indicates some kind of connective tissue disease like Marfan's or systemic lupus erythematosus or rheumatoid arthritis. If there's, for example, some kind of on the lower border, i.e. there's inferior rib notching, this indicates something like coarctation of the aorta. If there's both, that can indicate hyperparathyroidism. That's more of a separate point. That's not something that you'll probably need to pick up on a chest X-ray interpretation. That's more like SBA land. Okay, so let's now go through an example it's the exact same example that we've kind of gone through, but just so you know how it should sound. Okay, so here's the chest x-ray. I will confirm the patient name, the patient's date of birth, and the patient's hospital number. If there's any are there any previous chest x-rays, or is there a specific indication for ordering this chest x-ray? And I'll also check the date and time of this chest x-ray. Okay, let's assume that all of that information is given by the examiner. Okay, I'm going to be using the RIPE acronym to assess the quality of this image. So checking the rotation of the image, we can see that the spinous processes are equal distance to the heads of the clavicle, which means that the patient is central. In terms of inspiration, I'm able to count over 6 anterior ribs. This appears to be a PA view, as the clavicles are overlying lung fields and the lungs appear long and thin. And in terms of exposure, I'm able to see the vertebral bodies behind the heart. Therefore, this chest x-ray is adequately exposed, and therefore I'm able to interpret it, which I'll be using an A2E approach for. Starting off with checking the airway, I can see that the trachea is central and the carina is visible, and I can see the right and the left bronchi, and there is no obstructions. There is normal hilum size, and there's no enlargement. Moving on to B, I'm able to see normal lung markings over the lungs, and I will now compare the upper, middle, and lower zones, comparing the upper zones, middle zones, and the lower zone, and I'm not able to see any kind of asymmetries or any kind of abnormalities. No consolidation is visible in this chest x-ray. Moving on to circulation, as this is a PA film, I am able to determine the heart size. Since this chest x-ray shows that the heart is less than 50% of the thoracic cavity, there is no signs of cardiomegaly, and I can see that the heart borders are well defined. Moving on to checking the diaphragm, I can see that there is no costophrenic blunting, so there is no pleural effusion visible here, and I can see a normal gastric bubble. There is no free air below the diaphragm. And in terms of assessing if there's anything else, I'm not able to see any fractures in any of the bones. I can't see any obvious foreign bodies or any kind of soft tissue damage. All of this leads me to saying that this is a normal chest x-ray. So hopefully that kind of gives some kind of indication of how to interpret it. What I want to do next is just kind of go through a few key chest x-rays, just so you can have a quick idea of what they look like. Once you've seen one, you know what they look like. So starting off with this one, if you can pause them and kind of interpret in the same way, go through a RIPE and an A2E, but I'm not going to do that. So what we can see here, this is something called cannonball metastasis. Cannonball metastasis. This normally indicates some kind of renal cell carcinoma, which is then metastasized to the lungs, which is what gives kind of this appearance of loads of cannonballs. You also want to check the PSA if the cancer spread to the prostate. Okay, going on to the next one. Have a pause, see if you can work out what's the problem. I'm going to tell you. If you follow this down, this here is the NG tube. And the NG tube comes down and goes all the way into the stomach, which is fine. Going on to the next chest x-ray. Okay, have a pause, see if you can work it out. Also, yeah, this is what I mean. This says AP view here. And have a look at the lung size as well. The way that the lungs are kind of squashed and a bit like wider. Issue here is, again, an NG tube coming down there. This is not in the right position, this NG tube. This NG tube has gone into the right lung. And remember I said that the right lung is more likely to have any kind of foreign objects. After you put an NG tube in, and and you're not sure if it's in the right place, you're probably going to do a chest x-ray to actually see. Here we can see that it's not in the right place. Okay, let's go on to the next one. Have a go at interpreting this. This is like the typical COPD chest x-ray. What you're looking at here, there's a few kind of key buzzwords that you're looking for in a kind of, if it's like an SBA for COPD. So one is hyperinflation, i.e. we can see that the lungs are massive, right? Another thing is called bullae, which kind of means like air sacs that kind of develop in COPD. Another is a flattened hemidiaphragm, which we can see here as well. And then we can see this like hyperlucent lung fields. Which we can see that is really, really dark. If you just think about the way a person who has COPD, they're really struggling to breathe. When you get onto respiratory rotation, you're kind of you'll see a lot of COPD patients, and you should have a look at the chest x-rays and try interpreting them as well. Okay, let's go on to the next one. Give it a go. Okay, so what we can see here is the trachea is deviated. This lung is completely blacked out. There's no lung markings, i.e. this is now filled with air. The trachea is deviated. This indicates a tension pneumothorax of the right lung. So the solution for this is to go into the fifth intercostal space in the triangle of safety, which is kind of under the armpit. So you're basically using a needle, go in on the side there, fifth intercostal space, and release the air. Difference between a pneumothorax and a tension pneumothorax. Tension is life-threatening. The way you'll be able to determine that is the trachea deviated? Okay, next one. This is a right pleural effusion, which you can see here. So what this line here that I've drawn, this is basically a meniscus. If you think back to kind of like A-level chemistry when looking at in different tubes, like test tubes and stuff, you can see kind of a meniscus. It works in the exact same way in the lung. The reason why in a pleural effusion, the fluid will always be at the base of the lungs, because when you stand up, this fluid, it will go to the bottom of the lungs, which is why you then get this meniscus. For pleural effusions, there's two kind of main categories. So if I put pleural effusion, you've got exudative versus transudative. So exudative is basically if there's some kind of inflammatory problem. When you stick a needle into the lungs and start to remove that fluid, it's going to look cloudy because there's inflammation. If it is transudative, if you stick a needle in and start to remove that fluid, it's going to appear clear because there's some kind of organ failure problem. The main thing that you need to know about kind of pleural effusions is Light's criteria. Which basically just, it allows you to rule out whether it's an exudative pleural effusion or not, because there's a higher level of protein, because there's a high level of inflammation in the pleural effusion. Okay, going on to the next one. Let's have a look here, give it a go. Okay, so here we can see that there is a right lower lobe consolidation. Consolidation normally means some kind of pneumonia. In terms of pneumonia, there's a few kind of ones that you need to know about. One is kind of like community-acquired pneumonia. One is hospital-acquired pneumonia, and then one is kind of atypical pneumonias that you need to know about. The difference between community and hospital is a difference of 48 hours. As the person being in hospital for over 48 hours, it's hospital-acquired pneumonia. If it's in the community, it's community-acquired pneumonia. Atypical, there's a bunch of different organisms you just need to learn. and each of them have their own kind of different buzzwords to kind of associate and learn what they are, and from the question you'll be able to figure out what organism is causing this pneumonia. The thing to really kind of drill into your head for pneumonia is CURB65. So is the patient, the C stands for confused, U for urea, R for respiratory rate, B for blood pressure, and then 65 is patient over 65. From this, you're able to kind of get an idea of how bad is this person with pneumonia. Can it be managed in the community, given antibiotics, sent home, or do they need to be escalated to hospital? Okay, going on to the next one. Hopefully there shouldn't be too many left. Yeah, give this one a go. Okay, so the issue here is that the heart is on the wrong side. This is called dextrocardia. Just put this in here just so you don't get into kind of, one, so you just see what it looks like if the heart's on the other side, but so you also just don't get into kind of the habit of just going through the steps without kind of actually looking at the chest x-ray. Okay, let's go on to the next one. Have a go at this one. Okay. What this one shows is this problem here. I'll come over it. This problem here. That is called pneumoperitoneum. This is when there's free air under the diaphragm. This is bad. This is normally due to a perforated peptic ulcer. So peptic ulcers can divide into kind of two, so gastric or duodenal. The way to kind of differentiate between the two in like SBA land is a gastric ulcer is worse on eating, i.e. if you eat food, you feel really unwell. Duodenal is you eat food and yet it feels better. So i.e. gastric is worse on eating, duodenal is relieved on eating. There's a perforated ulcer. You're going to order an erect chest x-ray of the patient standing up, and then if they're standing up, the air will move up like that. This is an emergency and you will need to kind of contact seniors for help. Okay, the last one was a bit hard for me to actually give you a chest x-ray, so I just thought I'll just show you kind of this. This is the kind of typical signs that you'll see on a person with heart failure on a chest x-ray. So there's kind of an acronym. Again, everything is A to E in medicine. So A, B, C, D, E. So A stands for alveolar shadowing, which is here, which is kind of bat wing, so I like kind of enlarged hilar regions. B stands for curly B lines, which is kind of the interstitial edema, which you'll see these kind of lines going along here. C is cardiomegaly, i.e. the heart's massive. D is dilated upper lobe vessels, because now the your body's trying to kind of get its oxygen supply from higher up to like functioning parts of the lungs. And then E is pleural effusions, which is blunting of the costophrenic angles. Yeah, so that is basically heart failure on a chest x-ray. Learn A to E, it comes up all the time. And that is all of chest x-rays.